Welcome to the Deep Dive. We're here to take your sources and really zero in on the knowledge you need. Today we're jumping into a set of notes you've provided, focusing specifically on, well, a pretty fascinating parasitic infection.
That's right. We've got notes here detailing toxoplasmosis. It's caused by the Toxoplasma gondii parasite. Think of this deep dive as like a targeted run-through of these notes you have. We'll be highlighting the absolute must-know information.
The high yield points.
Exactly, the high yield points for really getting a handle on this condition.
Perfect. So our mission is basically to cut through maybe the dense parts and make the core concepts of toxoplasmosis clear and hopefully memorable for you, straight from your own study material.
Yeah, we'll break it all down, what the parasite actually is, how you can get infected, who's most at risk.
How it affects your body.
Right, how it affects the body, how doctors figure out if you have it, the treatment options, and, what the long-term outlook might be.
Okay, sounds good. Let's unpack this, starting right at the beginning with the fundamental definition in these notes. What exactly is toxoplasmosis?
Okay, so at its heart, it's an infection caused by Toxoplasma gondii. A really crucial point from your notes is that while cats are the primary hosts, that's where the parasite reproduces sexually and sheds oocysts, basically eggs.
Ah, the cat connection. That's always the first thing people think of, isn't it?
It is, yeah. But it can infect pretty much all warm-blooded animals, including us humans.
Okay.
And the notes specify it's an intracellular protozoan parasite, so it lives inside our cells.
Intracellular, right.
And the infection itself can range dramatically in severity. Sometimes it's barely noticeable, other times it's very serious. It's particularly a threat, the notes emphasize, for those with weakened immune systems and pregnant women.
Okay, so how does this tiny parasite actually get from, say, a cat or the environment into a person? What are the main ways someone can pick it up, according to the notes?
Right. The notes lay out several key transmission routes. Probably the most common involve ingesting those parasite eggs. They're called oocysts, which are shed in cat feces.
Okay.
So this often happens through contaminated soil or water, or maybe even, cleaning out a litter box without washing hands properly.
Right. Environmental contamination.
Exactly. And then eating undercooked or raw meat that contains the parasite cysts. That's another major route mentioned.
So food as well.
Yep. Then there's vertical transmission. That's from a mother to her fetus during pregnancy. That's a really critical one to understand.
Yeah, definitely.
And less commonly, the notes mention organ transplantation or blood transfusion as possible routes. So building on those ways you get it, the notes specifically talk about etiology and risk factors. The cause, like we said, is singular, the Toxoplasma gondii parasite.
And the risks just sound like they directly mirror those transmission methods you just outlined.
Pretty much, yeah. The notes highlight the key risk scenarios: consuming undercooked or contaminated meat, direct or indirect contact with cat feces, exposure via contaminated soil or sand-think gardening, having a weakened immune system. So that includes people with HIV/AIDS, those getting chemotherapy, or organ transplant recipients.
Right, the immunocompromised group.
And of course, being pregnant, those are the main situations where you're, more vulnerable, according to these notes. Understanding these is key for prevention.
Okay, now this is where it gets, for me anyway, really interesting. How does this parasite actually cause problems once it's in the body? The notes detail the pathophysiology. Can you walk us through that process?
Yeah, so the core mechanism described involves T. gondii invading host cells and then replicating inside them. But what's really key is that after this initial infection phase, the parasite forms these dormant cysts.
Dormant cysts.
And where do they mainly set up shop? Your notes are specific: the brain, muscles, and eyes.
Cysts in the brain, muscles, and eyes. Wow, that sounds like a pretty big deal.
It really is. And these cysts are essentially why the infection becomes chronic. Now, in someone with a healthy immune system, the body does mount a response that controls the active parasite, sort of keeping it locked down inside these cysts.
So it contains it, but doesn't get rid of it.
Exactly. The immune system generally can't eliminate the infection entirely, but it usually keeps it contained and dormant within those tissues. That's in immunocompetent individuals.
So the parasite kind of stays with you, just quiet, usually.
Largely, yes, in healthy people. It's this dormant cyst stage that's really central to the chronic infection, and it carries implications if that immune control ever, weakens down the line.
Okay, right. Moving into diagnosis then. If someone shows up with symptoms that might be toxoplasmosis, what else could it be? What are the differentials listed in the notes?
Yeah, this section's crucial for clinicians, obviously. If someone has those sort of nonspecific flu-like symptoms, aches, fever, fatigue.
Yeah, the common stuff.
Right. You'd need to rule out other common viral things like influenza or infectious mononucleosis, glandular fever.
Makes sense, yeah. Lots of things cause that.
Exactly. Now, if the symptoms point specifically to the eye, what the notes call ocular toxoplasmosis, you'd need to differentiate it from other causes of eye inflammation, things like uveitis from other causes, or maybe retinal vasculitis.
Okay. And what about when it affects the brain? The notes mention toxoplasmic encephalitis.
Yeah, that's a really serious presentation, particularly seen in immunocompromised patients. The brain lesions from toxo can actually look quite similar to other CNS issues on scans.
Like what?
Well, the notes list possibilities like CNS lymphoma, progressive multifocal leukoencephalopathy, or PML, and other infections too, like CMV, cryptococcus, aspergillus, nocardia, or even bacterial abscesses. So quite a few mimics.
Wow, okay. And in the case of a newborn who might have been infected during pregnancy, congenital infection.
For a suspected congenital infection, the notes say you'd consider other infections that can cross the placenta. The TOR-CH screen acronym comes to mind, though these notes list specifically rubella, herpes simplex virus, CMV, or syphilis. It's about distinguishing toxo from that whole group of potential congenital infections.
Right. Let's talk about how common this parasite actually is. The notes give us a picture of the epidemiology, both in a UK context, it seems, and globally. Yeah. How widespread is exposure?
Yeah, your notes highlight that the exact prevalence in the UK isn't, like, perfectly pinned down, but estimates suggest that maybe around 1/3 of the population has likely been exposed at some point.
1/3. That feels surprisingly high.
It does, yeah. And the notes also point to potentially higher risk in rural areas and for people in certain jobs, like farmers or gardeners. Again, think about that link back to soil and animal contact.
Makes sense. And worldwide, is it just everywhere?
Pretty much globally, yeah, although less so in areas with really harsh climates, like very cold or very dry regions. The notes show a huge range in what's called seroprevalence. That's the percentage of people with antibodies showing they've had a past infection.
How big a range?
Well, for instance, the USA might be somewhere like 16–40% exposure, according to these notes, whereas parts of South America see much higher rates, maybe 50–80%.
Wow, that regional variation is really striking.
Absolutely. And just focusing back on the UK for a sec, the notes give a figure of around 350 cases diagnosed annually. That gives you a sense of the number of actual clinical cases identified each year, rather than just exposure.
Okay, got it. So given all that background, what does it actually feel like if you get infected? The notes detail the clinical presentation, the symptoms people might experience?
Well, the first thing the notes stress is that many, maybe even most people, are completely asymptomatic, or they have very, very mild symptoms.
So you could have it and just never even know?
Often, yes. Now, for those who do develop symptoms, if they're otherwise healthy, the notes say it can resemble infectious mononucleosis or glandular fever.
So flu-like stuff again?
Yeah, flu-like symptoms, swollen lymph nodes are common, muscle aches, maybe a fever, headache, fatigue, that kind of picture. The notes do add that rare, severe cases are reported, even in people with healthy immune systems, but it's uncommon.
What about those eye issues we touched on earlier? Ocular toxoplasmosis.
Right, that's a significant presentation. And the notes say it can happen in both healthy and immunocompromised individuals. Symptoms often involve things like reduced vision or seeing floaters.
Oh.
And on examination, the typical finding is something called retinochoroiditis. That's inflammation of the retina and the choroid, layers at the back of the eye. You might also see scars from previous inflammation and inflammation in the vitreous humor, which is the gel inside the eye. Some atypical presentations can also occur, the notes mention.
And for babies infected during pregnancy, congenital cases.
In congenital infection, the mother herself often has no symptoms at all during the pregnancy. The severity for the baby, though, depends heavily on when the infection occurred during the pregnancy earlier, is generally worse. And importantly, issues in the newborn might not be immediately obvious at birth. They can develop later in childhood sometimes.
Okay. You mentioned earlier it could be life-threatening for immunocompromised patients. What are the common ways it presents in that specific group?
Yeah, this is where that dormant parasite we talked about can reactivate and cause serious problems. Toxoplasmic encephalitis brain inflammation is very common, according to the notes, and that can lead to a whole range of neurological symptoms depending on where the lesions are.
Okay.
The notes also list other severe presentations in this group, like chorioretinitis again, severe eye involvement pneumonitis, which is lung inflammation, and sometimes involvement of multiple organs. It becomes much more dangerous.
Right. So if a doctor suspects toxoplasmosis based on these kinds of symptoms or the patient's history, how do they actually confirm it? What tests are described in these notes?
Okay, the notes list several key diagnostic approaches. Serology is primary, so looking for antibodies against the parasite in the blood.
Blood tests, basically.
Exactly. They mention specific tests like the Sabin-Feldman dye test, or DT, which is kind of a reference method, alongside more common ones like IgM, EIA, and something called the IgMIGA immunosorbent agglutination assay, or ASAGA. These help detect recent or past infection.
So checking if your body has mounted an immune response.
Precisely. The notes also list some more advanced lab techniques, things like molecular diagnosis using PCR, which looks for the parasite's DNA, enhanced immunohistostaining if you have a tissue sample, and other antibody tests like the Toxoplasma IgM immunoblot, which can help confirm results or figure out the timing of the infection sometimes.
Do scans or imaging help with the diagnosis?
Yes, definitely, especially when the brain is suspected to be involved. The notes say MRI or CT scans are very sensitive for detecting those brain lesions we talked about, particularly in suspected toxoplasmic encephalitis in immunocompromised patients. For congenital cases, fetal or neonatal ultrasonography is mentioned. But the notes clarify this isn't strictly diagnostic for the parasite itself, more useful for looking for structural abnormalities or signs of damage caused by the infection.
Right, seeing the effects. And there was something in the notes about a trial of therapy. What's that about?
Yeah, that's an important practical point mentioned for immunocompromised patients, specifically those who present with multiple brain lesions where toxoplasmosis is, highly suspected.
Right.
Because getting a definitive diagnosis from, say, a brain biopsy can be risky or take time. Clinicians might start empirical treatment. That just means treating based on the strong suspicion even before you have absolute lab confirmation.
And does it usually work if it is toxo?
The notes state that if it is toxoplasmosis causing those lesions, you'd typically see clinical improvement pretty quickly, like within 7 to 10 days of starting the specific treatment. So it can be diagnostically helpful in a way.
Got it. Okay, so once a diagnosis is made or strongly suspected, how is toxoplasmosis typically managed? The notes cover treatment and also prevention strategies.
Yeah. So first off, does everyone who tests positive actually need treatment? According to these notes, no.
Oh, okay.
Healthy individuals who have mild symptoms or maybe no symptoms at all often don't require specific anti-parasitic treatment. Their own immune system usually handles it and keeps it dormant.
Right, so who absolutely does need treatment then?
The notes specify treatment is needed for severe cases or for anyone with a weakened immune system who has active disease. Also for active ocular toxoplasmosis.
And what's the treatment?
The standard drug combination listed is pyrimethamine and sulfatazine. The notes also mention that folinic acid is usually given alongside this.
Why the folinic acid?
It's mainly to help prevent some of the potential side effects of pyrimethamine, particularly on the bone marrow. It's especially important in immunocompromised patients, the notes state.
Okay. And for those with weakened immunity, is treatment just a short course?
No, often not. The notes state that for immunocompromised patients, after the initial treatment course to clear the active infection, long-term prophylaxis that's preventative treatment is often needed.
Stop it coming back.
Exactly. To prevent that dormant parasite from reactivating and causing severe disease again.
The notes also mention pregnancy cases needing specific management.
Yes, absolutely. Managing infection during pregnancy is complex and really requires specialist consultation involving obstetricians and infectious disease specialists. The notes even state, quite seriously, that termination of pregnancy may be an option that's considered in certain severe situations, depending on the timing of infection and potential fetal damage.
Wow, okay. What about stopping infection in the first place? Prevention.
Yeah, the notes bring it back to basics here, emphasizing safe food handling and good hygiene measures.
Which ties back to how you get it.
Exactly. Making sure meat is cooked thoroughly, washing fruits and vegetables, washing hands well after handling raw meat, or after contact with soil or sand like gardening. And of course, careful handling of cat litter, especially for pregnant women or immunocompromised individuals.
Simple but important stuff.
Very. The notes reiterate that most cases are self-limiting in healthy people, but prevention is absolutely key for avoiding eye involvement and, critically, for protecting those vulnerable groups.
Okay, finally then, let's look at the long-term picture. What's the prognosis generally like, and what potential complications are listed in these notes?
So, for healthy individuals with a robust immune system, the notes say the prognosis is generally quite good. Most of these cases resolve without causing any lasting problems.
That's definitely reassuring for the majority of people who might get exposed, given how common it seems to be.
It is. However, the notes clearly emphasize that severe cases, congenital cases, or cases in immunocompromised individuals are very different. These situations require prompt treatment and can unfortunately have significant long-term consequences.
And can be life-threatening.
Absolutely. Crucially, in individuals with weakened immune systems, the infection can definitely be life-threatening if not managed properly.
But there was a slightly more hopeful point in the notes about one specific immunocompromised group, wasn't there?
Yes, that's right. The notes specifically mention an improved prognosis observed in AIDS patients over recent decades, and this is largely attributed to the effectiveness of modern antiretroviral therapy, or ART.
How does ART help with toxo?
By suppressing HIV, ART allows the patient's immune system to recover, sometimes significantly. This restored immune function means the body can better control the Toxoplasma parasite again, reducing the risk of reactivation and severe disease.
That makes sense. Okay, so what are the specific types of problems or complications the notes warn about?
Right. Several key ones. Eye problems, ocular toxoplasmosis, are significant, particularly the risk of recurrent inflammation leading to vision impairment. Neurological issues are also major, especially encephalitis, inflammation of the brain, which can cause seizures and other deficits.
And what about in babies infected before birth? Congenital toxoplasmosis.
Yeah, for congenital cases, there's a risk of various developmental abnormalities. The notes specifically highlight nervous system involvement, which can lead to seizures, developmental delay, hearing loss, or other CNS problems that might manifest later in life. The notes also mention that for immunocompromised patients, the acute infection can potentially cause hemodynamic issues, basically, problems with blood flow and blood pressure. And there's that risk of life-threatening involvement of major organs, the brain, heart, or lungs.
Any other rarer things mentioned?
Yeah, the notes list rare complications like panhypopituitarism or diabetes insipidus, particularly reported in AIDS patients with CNS toxoplasmosis.
Okay. And the notes included a couple of specific statistics in the prognosis section too, didn't they?
Yes, they did. They mentioned that if a mother acquires the infection during pregnancy, the overall risk of transmitting the parasite vertically to the fetus is around 26%.
So about 1 in 4.
Roughly, yeah, on average across the whole pregnancy. And among those babies who are infected congenitally, the notes say about 1/3, so 33%, develop retinal lesions, though thankfully severe visual impairment isn't that common among them.
Okay. So wrapping it up, while serious outcomes aren't like a certainty even with infection, they are a very real and significant risk, especially for these specific vulnerable groups, pregnant women, their babies, and the immunocompromised.
Precisely. That's the key takeaway. And the notes really underscore that prevention through those basic hygiene and food safety measures is paramount, especially for those high-risk groups. It also mentions that routine population screening for toxo isn't universal and varies quite a bit from country to country.
Well, that was a really thorough deep dive into your toxoplasmosis notes. We've covered the definition, how you get it, who's most vulnerable, how it actually affects the body, the pathophysiology.
Yeah, how it's diagnosed, the investigations, how it's treated and managed.
And importantly, the prognosis and those potential complications.
We certainly have distilled the core information from these notes. I think it's really clear that while it's often silent or mild in healthy individuals, toxoplasmosis absolutely demands attention because of the severe risks it poses during pregnancy and for anyone with a compromised immune system.
Yeah.
And understanding those transmission routes, the undercooked meat, the cat feces, the soil contact, that really is the front line of prevention, isn't it?
Absolutely. It's such a potent reminder of how things like food safety, environmental contact, animal contact, and our own immune status are all interconnected when it comes to infectious diseases like this.
And this leaves us with an interesting question, perhaps, for you to consider, based on everything we've discussed from your notes. Given how apparently widespread exposure to Toxoplasma gondii is globally, and the potentially severe outcomes for these specific vulnerable groups, how effectively do you think current public health messages and awareness campaigns are actually getting across to the people who need them most?
That's a good question.
What further steps might make a real difference in reducing infections in, say, pregnant women or those with weakened immunity.
Yeah, definitely something to think about. Well, thanks for joining us for this deep dive into your toxoplasmosis revision notes. We really hope going through them in this way helps solidify those key points for you.